Welcome to Business Talk, a global podcast series where we bring you closer to some of the world's most distinguished scholars and their impactful ideas. I'm Deepak, your host from India. It is a pleasure to welcome Dr. Anna Kirkland. Her work begins with a deceptively simple question. Can the law truly protect patients from discrimination in healthcare? And if not, what stands in the way? Dr. Kirkland is the Kim Len Scheppele Collegiate Professor of Women's and Gender Studies and an Arthur F. Thurnau Professor at the University of Michigan, where she brings together law, policy, and lived experience to examine some of the most pressing inequalities in modern healthcare systems. Trained at the University of California, Berkeley in both law and social-legal studies, her scholarship sits at the intersection of legal frameworks, health policy, and social justice. Across her work, she has consistently explored how institutions meant to protect individuals often fall short in practice, whether through her earlier books on fat rights, vaccine injury, or the moralization of health, or through her leadership at the Institute for Research on Women and Gender. Professor Kirkland has built a body of work that challenges us to rethink how fairness operates in deeply complex systems. Her current research, supported by the National Science Foundation, turns to one of the most important yet contested provisions in the US health law, Section 1557 of the Affordable Care Act, focusing particularly on how protections against discrimination, especially for transgender patients, are implemented on the ground. In her latest book, Healthcare Civil Rights: How Discrimination Law Fails Patients, she takes us inside this reality, revealing the gaps between legal promise and patient experience, and asking what it would take to make mental health care equitable. In today's episode, we explore these questions with her. So without further delay, let's begin. Professor Ahana Kirkland, thank you for accepting our invitation. It's an honor and privilege to welcome you to Business Talk.
Thank you so much. It's great to be here.
Thank you. Professor, your book argues that Section 1557 of the Affordable Care Act is, in your words, a thin, raggedy civil rights strategy. What does that phrase mean to you, and what was the moment in your research when you realized the law was structurally set up to fail?
Thank you so much. I really like that question. Yeah, I found that Section 1557 is what I call thin and raggedy for a lot of reasons. But let me first back up for a minute. So, this is the non-discrimination clause in the Affordable Care Act. And when it was passed, I really wanted to understand how this was going to be implemented because I saw that it was going to be really complicated. Healthcare is a huge system in the United States. Discrimination law is also a very complicated thing in the United States, and seeing these things come together would be really fascinating to study. And the sex discrimination part of it was new when the Affordable Care Act passed. We had not previously had a ban on sex discrimination in healthcare for patients. So that's the part I was interested in. And when I first looked at the clause, just what does the law actually say? It's very short. It's just really a string of references to other civil rights laws. Like, oh, the things protected under these other civil rights laws is what we're going to protect as healthcare discrimination. And I thought, well, that's a really weird way to write a clause in the law. Like, wouldn't you say more about what it's supposed to mean? So it's thin in that sense. It has almost no legislative history. There is no legislative history. There weren't congressional hearings, before the law was passed about what health discrimination even is, what we understand it to be. And it's raggedy because they're just a lot. Raggedy means with holes and need of repair, with clothes. And so we knew that civil rights is really underfunded in the American government. We, we just have made a political decision not to have these parts of the government very well funded. And so we really rely on individuals to bring forth claims. Our agencies really don't do nearly as much as they could. So that makes it a patchwork right there because individuals have to bring forth claims to even use the law. And then we know that the organizations being regulated have a lot of power to interpret the law in their favor. So I knew all that already, and so I thought, uh-oh, I don't know how this is going to go. So really, when I saw that clause for the first time and I saw how just bare bones it was, And then when I started calling to interview people, because this is a multi-method study that involved interviewing folks on the ground in hospitals who implement this law, and I found, a lot of them didn't even really know what the law even was or how it was supposed to work. And that's when I realized how just ambiguous it was. And then they held positions outside the law that with no civil rights training, and they were in the patient experience department, which I know we'll talk about later. So that's when I really saw, wow, this is going to be different. This is going to be doing something completely different that's probably not going to work very well.
Professor, you opened the book with Sam, a transgender man whose baby was stillborn, partly because a triage nurse failed to recognize him as a pregnant person. What does Sam's case reveal about the gap between what discrimination law promises and what actually happens in an emergency room?
Right. This was a really sad case that I learned about it because a lot of people in my interviews were telling me about it. Like we really realized that we needed to address these problems when there was some sort of traumatic or embarrassing thing that happened at at a hospital where they weren't able to provide the care that they had hoped to. So the regulations for this law said that you had to treat patients according to their gender identity in order not to discriminate against them, which again sounds pretty simple, but when you think about how complex that actually is in a healthcare organization, even when one truly wants to comply, as they did at this hospital. Um, so it's just really hard to know all the things that you need to know about someone when they come in as a patient to be able to both recognize them in the right way. So, what is their gender identity? How should you address them? What is the proper name? But also, what conditions might they have? What bodily organs do they have or not have, right? You need to know very specific things about their body to recognize them as someone in need of a certain kind of care. And then you need to provide the care. So, what I really argue throughout the book is rights involve recognition and provision. And this is fairly complicated. So, in healthcare, we need to know, for example, do you need a cervical cancer screening or a prostate cancer screening? What language do you speak that where we can communicate so that you can understand your care, right? All of these things are part of treating people fairly and justly. So Sam is a man, and they recognized him as a man, which was correct under his gender identity, but he was also pregnant. So you have to have a capacious enough understanding to know that that is possible. Now, he had also lost his health insurance and his medications. So he was presented a situation that's not uncommon in the United States where someone had been cut off from care in ways that made the situation, got him into that pretty bad situation. Um, so what's really challenging, and I love the way you put it at the beginning that it's come through these very complex systems. So this recognition and provision has got to happen through the medical record systems. If there's AI involved, we need that to work. Staff training, insurance, all of those things would come together to help everyone understand, who is this person and what do they need in a fair way. And discrimination law, as we'll talk about, intervenes in all of these things, but fairly weakly. And it's just isn't enough. And Sam's case sadly illustrated that.
Professor, you used the metaphor of light refracting through a prism to explain what happens to civil rights when they enter the healthcare system. Can you walk us through what refracted rights means in practice and how hospitals quietly absorb and deflect discrimination complaints?
Yeah, so I kept thinking about refraction because I kept thinking about how when something tries to come into a space and then it just gets kind of broken apart and turns into something else. And so that's what happens when light goes through a prism. It breaks up into other types of light, right? The Pink Floyd album cover, right? One of the most famous album covers, and um, is it a representation of that? So what happens was we said, okay, let's have non-discrimination in healthcare. Let's have this law and apply it to all these healthcare settings. And I use hospitals because I mostly looked at hospitals, but I also looked at clinics and other kinds of settings, right? So it's all kinds of healthcare settings. But these are two really important fields kind of coming together, a legal field coming into a health field. And, what is going to happen there? And what I found was that the law, people implemented the law in the patient experience department for the most part, which means the regulations said that you had to appoint someone in your hospital to handle these complaints. But the regulation said you could give it to somebody who already has another job doing something else. And so there already were pre-existing rules that said you had to have a grievance officer and a complaint process. And so what happened was that this person just, the same person got handed that job, and they were mostly in these patient experience departments, which under a different law, reforms around the ACA, had said, well, we need you to show that you have patient satisfaction in order to get full reimbursement for your Medicare services. So we want to see that hospitals are getting high scores on patient satisfaction surveys. So how this came together is that the folks who were handling rights claims, like claims of discrimination, ended up handling the same kinds of things as I got the wrong food, or I waited too long for my appointment, or I showed up and there wasn't a parking place, or, somebody was rude to me, where we don't know what rude really means. Does rude mean discrimination, or does rude mean just grouchiness or poor care? All those things get dumped in together. I lost my dentures. All those kinds of problems that someone might have got lumped in together in this department, where the aim was to make people feel satisfied so that they give a better satisfaction score so that the hospital doesn't get money withheld. So what I found was this really high motivation, right? There's a financial incentive, but to do something kind of totally different than what we might think civil rights enforcement means.
Professor, research found that many hospitals route discrimination complaints to the patient experience department, a relatively powerless, feminized part of the organization. How does framing a civil rights violation as a bad patient experience effectively bury the problem?
Right. So I really, I spend a lot of time in the book on this. And I should also say, if anyone's interested in the book, you can certainly buy a copy. I don't make any money off of them, but it is also available free and open access. So if you just Google healthcare civil rights, you can get to a free copy online. I published it that way on purpose so that it would have as much access for folks as possible. So, you know, on the one hand, having someone apologize to you and try to fix your problem and try to make you happy is not a bad thing, right? That could be a very good way of managing things. But a customer service problem or a patient problem is not the same thing as a rights violation. And if we want to have a national policy of rooting out health discrimination, then we probably need something else, because it's not necessarily a problem of people with bad attitudes. Um, there are systems considerations. So, for example, the people who handle these patient problems have used software programs with drop-down menus to classify the problems, and the drop-down menus have certain entry fields. And if you don't have an entry field in your drop-down menu that can say that it was discrimination, then you're not going to classify it as discrimination, and then it's going to literally just never appear ever again in your system as a discrimination problem. So that's just one like literal way where a system can misclassify things, or you just will never find out. Maybe somebody was rude to me. Well, you don't know if they called you a racial slur or if they just did something else that was rude but that was not discrimination, right? And we might really care about figuring out which one of those things might have happened, but the system might not be able to do that. So it's burying, but also failing to see a problem as a problem of discrimination, and seeing it as something else that you happen to have a tool for and an incentive for. Remember, I said that there is a financial incentive to keep the patient satisfaction surveys high. So you might want to sort of fake apologize to the person or tell them that it's going to be fixed. But then, once they fill out that survey, hopefully, your problem's kind of been solved. And another big thing I emphasize in the book is that, in order for things to be effective, you have to have people with the power to fix things. And none of these administrators had the power to discipline doctors. Only doctors discipline other doctors. And, this is why I call them out, describe them as sort of powerless. It is a mostly women administrators, so powerless in the hierarchy of the American hospital. And so you have the people who are identifying the problems who don't necessarily classify them in the right way, and then they don't have the power to fix what might have happened, even if they did classify it correctly. So, there's just no way to, that's just a systems failure there. And one last point I want to make is that a lot of discrimination is not even within the realm of the patient's experience, right? Just think of like if you're under sedation or if the problem is that the doctor has forgotten about you and you never hear anything, or the doctor thinks that you're not the kind of person who would have this illness. And so they don't even think of diagnosing you and you have a missed diagnosis. All those things are going to be outside the patient's experience, right? You're not going to know anything about that. You will not have had an insulting experience, but you will still have suffered a real harm. And so we can't have a system that relies on, the patient to identify these problems. And we'll get to that when we get to, I know, algorithmic discrimination, which is a big way that ties in.
Professor, you dedicated an entire chapter to how insurance companies broker healthcare civil rights. How do insurers use concepts like medical necessity and cosmetic exclusion to deny gender affirmative care, even when a plan technically has no categorical exclusion?
Yes, thank you. In this chapter, I start with the best case scenario. So, someone who's trans, but you have health insurance and you've actually used it recently to obtain gender affirming care. So those are the folks that I was focused on in this chapter. Um, and even then there are problems. So the 1557 regulations said that non-discrimination law applies to the insurer because they're part of healthcare provision, but it doesn't mean that they have to supply any specific service or procedure. They can still use all of their utilization management techniques. So just that in the law is a very big loophole, right? You don't have to do anything in particular. You just can't discriminate. Well, what does that even mean, right? So again, very ambiguous, leaves a lot of discretion to this very powerful actor, the health insurance company. Um, and on top of that, most working adults in the US who have health insurance have it through their employer. And they have it under a self-insured employer, which means the employer itself isn't regulated under 1557 because the employer is not a healthcare provider. They're just Walmart or something like that. And Section 1557 applies to healthcare entities. So it applies to some insurance companies, but not the employers that are actually devising a lot of the insurance. So then what I found was people, the trans and non-binary folks who were trying to use their insurance still had a ton of problems using it in a fair way. So there's lots of hoop jumping. So they had to be in counseling for a certain period of time. They had to get a certain number of letters from doctors, and those letters needed to be written in a certain way. Um, one person talked about needing prior authorization, but calling and calling, and no one would tell him what he needed to do to get the prior authorization. Another person talked about, their HR, human resources at their company had said, oh, this is covered now. But then this was a self-funded plan. So they had a third-party administrator who's a health insurer administering their plan. But then the HR said, oh, it's covered. And the person at the insurance company said, well, we don't know. And then they just went back and forth blaming each other for months and months while he had to spend his own money to pay for care that his company had told him was covered. And eventually, months and months later, they got it worked out. but this is enormously burdensome and takes a ton of time and loss of money and worry and bother. And the folks that I interviewed were experts in figuring all this out, but it was really, really burdensome, even though they supposedly had this coverage. If you had a name change, but that wasn't reflected in the billing, then they would think maybe this is a different person for whom the care has been ordered. So that could cause a lot of problems. Um, and then finally, for someone like who's a trans woman who wants facial surgeries or an Adam's apple shaving, these would sometimes be rejected as cosmetic by the insurance company. But if you think about it, we see people through their gender, with our clothes on in public, face to face. And the face and how your face appears is really, really important for projecting your gender identity and being safe from violence, frankly, and discrimination and harassment. So the trans women who needed facial surgeries certainly didn't think of them as cosmetic, but the insurance companies often did. And that was a major point of contention.
Professor, the book describes a direct collision between religious freedom and healthcare civil rights, where entire hospital systems funded by federal tax dollars can deny care to LGBT patients. Where should the legal line be drawn between an institution's religious beliefs and a patient's right to non-discriminatory care?
So, right now what I'm arguing for is that we should accept that someone's right to health care includes all the medically necessary care that's supported by evidence for their condition, and that a hospital's religious status doesn't mean that they can deny it on religious grounds. But right now in the US, that's not the case. So, for example, if you're a woman giving birth and you want to get your tubes tied for contraceptive purposes at the same time as you're having a planned C-section, which is much safer, do it all at once instead of having to have two separate procedures. But Catholic hospitals will not do that because of religious doctrine. And yet they are able to get all of the federal funds that other hospitals get. So, what I say in the book is that individuals hold religious beliefs and conscience objections, but institutions shouldn't. So no doctor should be forced to do a procedure that violates her religious beliefs. But right now, hospitals are allowed to fire anyone who doesn't follow their rules. Um, a doctor can be fired for providing care like contraception if the institution doesn't agree. And so the institution gets to hold this power. Um, and I just think it's in our care, in our system, it's just gone too far in that direction. And for example, there is no conscience right to provide care. Um, you still can't go against what, say, your Catholic employer says you can and can't do. So I think we should have a rebalancing of that. Unfortunately, that's not the way things are going now, but I do think it's really worth thinking, what is the proper balance between religious protections and non-discrimination. And, people should be aware right now we're going in a direction where very particular religious beliefs, conservative Catholic and evangelical Christian in the United States for the most part, are um, are winning Supreme Court cases and being able to discriminate and to overturn our discrimination doctrines in favor of religious freedom, but in a very narrow sense. And I think it's not good for healthcare. It's not good for our democracy, and I think we should rebalance back on that.
Professor, describe both the largest expansion and the largest contraction in trans rights protections happening within a single decade. What political and legal mechanisms have conservatives used to dismantle healthcare civil rights? And how durable are those dismantling strategies?
Yes, we're certainly, it was true when I wrote the book, and it's certainly even more dramatically true since then that we're seeing the largest expansion of rights. One example is what that 1557 really accomplished, for example, was saying that you couldn't have these exclusions for gender affirming care in health insurance. And that resulted in a lot of health insurance plans removing the categorical exclusions for gender affirming care that they had. So that was a really significant expansion. And then now, of course, we've moved from, it's discriminatory not to provide gender affirming care to you're allowed to make it illegal to provide it. So it's really just um, a tremendous shift, not in the direction that I would like, as you can tell. But the way that's worked is through the courts. So through what we call forum shopping, which is where you can bring a case to a particular district court judge that will, overturn 1557 regulations, for example. So that's quite easy to do. And conservative legal organizations have been doing that. There's Trump's executive orders, which on their face were not quite as powerful as folks sometimes interpreted them to be, but which have turned into regulatory proposals to withdraw federal funding from all kinds of entities if they don't, for example, act as if there are only two binary sexes that can never change. And that is effectively an erasure of transgender identity entirely. They're, the courts have been giving more power to religious claims, as I said, although really only the certain conservative Christian religious claims to religious liberty, meaning that they don't have to comply with discrimination laws. Now, the ACA and the clause itself of Section 1557 is still there. And courts can still interpret it in other ways, and courts have disagreed over what the clause itself means. So some of these things are very durable. Some are more durable than others. The executive orders can easily be overturned by another president. Um, Regulations can be withdrawn and rewritten. That takes a year or two. And we have seen in this area just a whiplash of different regulations, Obama regulations and then Trump first administration, now second administration. So really pulling that back and forth. So that could continue to happen. But the Supreme Court rulings are quite durable, and those would require major reforms, probably reforming the entire Supreme Court. And, Congress would have to act, which, a major feature of American politics recently is that Congress has not been acting. So, all these things could be fairly durable for a while.
Professor, Section 1557 now prohibits the use of discriminatory clinical algorithms. But you note that patients have no idea these tools exist or how they work. How is algorithmic bias in healthcare different from human bias? And why is it so much harder to fight through traditional civil rights law?
Thank you for this. This is hugely interesting and really complicated. So, just to give some examples, we know, for example, that there were race-based adjustments to spirometers that measure lung capacity, and these were based on slavery era ideas that Black people have reduced lung capacity. And so, when we use those tools, doctors would miss asthma diagnoses or undercompensate Black veterans with lung problems. And in COVID, we learned that the pulse oximeters, the thing that goes on your finger and reads your blood oxygen level, didn't do very well on darker skin, right? So it made wrong decisions in COVID treatments and triaging, right? So we know these things in these tools and in software tools are out there, and they're based on things from maybe decades ago that we don't, when you're using it, you don't necessarily know that. And so the new regulations, actually, it's broader than algorithms. They call it patient care decision support tools. So anything you're using to try to make decisions about, risk that a patient might develop something, or do they qualify for a certain treatment, or do they get a warning that pops up in their chart, all these kinds of things that are trying to help doctors organize their workflow and all the information that they have to deal with. Being a doctor has become very, very, information intensive and with a lot of burdensome, um, what we used to call paperwork, but of course now it's electronic work. And so we're trying to make that easier and smarter, but the risk is importing some of these discriminatory things into these tools. And then how do we know? I think that's the big question. So the regulation is, again, it's fairly weak. It says that the end user in the healthcare system has to make reasonable efforts to comply with non-discrimination. So that doesn't say you have to succeed, right? It just says you have to make reasonable efforts. And so bureaucratically, organizations are very good at always making sure that they're able to document that they make a reasonable effort, right? That's not hard to do. What's really hard to do is to understand what's going on with the tool and figure out how you might fix that. So, and it's complicated here legally because HHS shares regulatory power in this area with the FDA, which regulates AI software as a medical device. So, both of them are regulating, although neither as strongly as they could. So the algorithmic bias might be hidden in the tool from the end user. Although we should remember that our human bias is often hidden from us, from ourselves as well. So the fact that it's hidden doesn't distinguish it. Um, but what's really important is that, it's not an individual conscious thought. There may be no decision maker, there's no intention. And these are the things that discrimination law is really good at trying to figure out. Like, did you intend to treat this person wrongly because you dislike them or you devalue them? And that's not what's happening here, right? It's things that are just getting built in. So you have to have an approach to discrimination law that looks at the outcomes. But right now politically, Republicans are trying to end disparate impact discrimination, which is where you look at the impact to see if the discrimination happened. And that's going to be really difficult because the only way we're going to be able to figure out if there's bias in these tools is looking in how they work and hopefully intervening in that. And we should have regulations to intervene at the production end to make sure these things don't get baked in and that they're tested adequately. But right now we don't have that in place nearly enough, and all of us, including doctors and providers who are using this, and certainly patients, we just have very, very little understanding of how this might be working.
Professor, you draw a powerful contrast between the Swiss hospital desegregation of 1956, driven by President Johnson, threatening to withhold Medicare funds, and today's toothless enforcement of Section 1557. What makes desegregation work, and why can't we replicate that political will today?
Right. And I did write a fair amount about, President Lyndon Johnson and the desegregation of hospitals because it's really not something we study and teach as much. When I learned about desegregation, it was all education, school desegregation. But our hospitals were completely segregated throughout the South until the mid 1960s. We had a segregated blood supply, all the separate waiting rooms. The whole apparatus of racial segregation in the United States was applied to our healthcare system. And President Johnson, when the Medicare program was implemented and hospitals could join it and start billing and getting federal funds from Medicare, they had to desegregate. And there was a whole program of going and checking to see whether that really happened and threatening to withhold funds if they didn't. And within really a matter of months, almost everyone complied. Um, and then, interestingly, what happened for many decades after that is there never was any withholding of federal funds. So, in a way, it's such a powerful tool to threaten to take away federal funds if you don't comply. Um, it's almost too powerful to use. So, because it hurts people, it hurts the medical care. So, part of the problem in the design of the law and the legal remedy is that you don't want a remedy that's just too harmful and too extreme to really use. And so, what's kind of ironic now is that this is what President Trump is threatening to do, right? All this withholding funds, but no one had ever done it before. So it was not a tool that it's used, and then now we see what chaos it causes to try to use it. And so clearly we need something else. We need other ways of enforcing civil rights laws. Um, because then we just withdrew from that tool almost entirely. And so it's true, we don't have the political will. We haven't had the national conversation about what this law should mean. Um, the political will is right now. Um, I mean, I would argue it's being taken in a much further direction than the American public has ever endorsed. But we really have not had a full conversation about what healthcare discrimination even means, why we might be against it, what we might want, say, artificial intelligence companies to be doing, or health insurance, or all of these things. We just haven't, since the civil rights era, um, organized around those things or had enough education and conversations about those things.
Professor, I would like to conclude this episode with one last question. At the end of the book, you resist the critics who say we should abandon legal institutions altogether and instead offer concrete reforms, from empowering civil rights coordinators in hospitals to rebalancing conscious protections. If you could pass one single reform tomorrow, what would have the greatest impact on reducing healthcare discrimination?
Thank you. And this has been a really great conversation. And if anyone is listening to this and you are a hospital administrator, for example, I close the book with a whole bunch of policy recommendations or change recommendations. And I make them kind of for everybody, for someone who wants to make small changes in the hospital to like the biggest possible things that we can imagine that are far, far outside the realm of political possibility. So it's something that I can do as an academic. But I can think as broadly as possible, even if because I'm not a political advisor or something like that. So if anyone is interested in what some of these solutions might look like, the last chapter of the book does try to get really detailed. But the biggest thing, the thing that would be the biggest and accomplish the most, is to have universal health care in the United States with a provision for non-discrimination. That means you can't deny care based on animus against members of a group, like dislike, prejudice, and that we can't have health disparities on the basis of race, gender identity, all these things. We can't have these health disparities that emerge even without intention that go unchallenged. So wherever we see health disparities emerging, there needs to be some duty to investigate them and see what might be going on. That's how you're going to catch the algorithmic discrimination and other things. But applying care universally for everyone in the United States would mean that we would just be able to provide care in ways that would fix a lot of this. Because in the United States we're kind of fixing things with civil rights law, or trying to fix things with civil rights law that we could fix with just better provision. I mean, remember Sam, he didn't have health insurance at all. His health insurance had lapsed and he didn't have any, and he didn't have access to his medications. And so that was a major problem that he was having, and so we don't have to have any of that. We could fix all of those things together. And, so non-discrimination then looks like a little bit of a just trying to come in at the edges, when we could have universal provision for everyone. And then we would have to really think through what it means not to discriminate. We can't withhold care for certain groups because we dislike them. And then we also can't have these health disparities to emerge, and then, we just let them grow and grow for decades.
Listeners, healthcare civil rights is not just a legal critique. It is a mirror held up to a system that promises equality but too often delivers silence. Professor Anna Kirkland's work reminds us that laws written on paper must be felt in the lives of real patients, people like Sam, before they can truly be called civil rights. If today's discussion has made you think differently about who gets care, who gets heard, and who gets left behind, then it has done its job. Thank you for listening to Business Talk. Until next time, keep questioning, keep learning, and keep the conversation going. Professor Anna Kirkland, thank you so much for being with us today. Your work is a vital contribution to how we think about justice, healthcare, and the rights of every patient. Thank you once again.
Thank you so much.